So one of the things that we also noted is that staff within the clinics were not aware of the poor retention. And especially in RCH clinics, we found that there was little or minimal skills in chronic care management. And thus we had clinics that were running care without appointment or follow-up system. We also found that there was weak community linkage. And here in particular, I'd like to mention that in many of the facilities that we visited already had an ongoing ART clinic within the same site. So in this setting, we would find a good community linkage with the ART clinic, but not so with the PMTCT or RCH clinic. And we think that this could explain why, could partly explain why we're seeing some issues with poor retention. And in some facilities where we noted good retention, actually healthcare workers were very much proactive in tracking clients, and some reported using cell phone reminders, and some reported using community healthcare workers where they were available or volunteers. So of note is that also stockouts were not uncommon. So although we are reporting stockouts within the period of assessment, but service providers reported that stockouts were there before the rollout of option B+, and this actually affected the rapid test kits and the TLE, but healthcare workers corroborated that other regimens were available, and I think this was attributed to high demand into TLE than other regimens. In terms of capacity and space, is that in many of the RCH clinics, that is reproductive and child health clinics, had limited space for confidential ART services. So you'd find women who are queuing up for antenatal care services are also in the same place where HIV services are also provided. So the confidentiality and secrecy was not optimum. And then in many of these facilities, as I've mentioned, that we have ART integrated within the RMNCH. So we have the same healthcare providers who is providing antenatal care services, who is also providing immunization, family planning, and now PMTCT option B+. So they are quite overwhelmed, although we know that the number of pregnant women who are HIV positive is few, but the overall portfolio is quite huge, and therefore this in some way compromises the quality of services that they provided. Of note again is that within these facilities there were existing ART clinics that had experience, and I would retaliate, good experience in terms of providing ART care and chronic care. And many of these reproductive and child health clinics were not tapping on these existing skills and resources to improve care within the RCH setting. So the high workload, the limited space for confidential services and things like that actually have a domino effect, where we believe that there is inadequate adherence, assessment, counseling, and support that ultimately affect retention and other parameters of care. We also noted shortage of current and up-to-date data tools, and we noted many data errors, and these were cited to be caused by inadequate knowledge and understanding of the ART data and patient management and chronic patient management. I think of immediate concern within the team was that why our counter ART clinics are performing good while the RCH clinics were performing poorly. But I think the skills, the knowledge is imparted in short term during the training, but the skills actually takes some considerable time to hone. And I think, although not not optimum, it is quite rude to compare their skills to those within the RT clinics. So what are our key findings? Our key findings were that option B plus, what we call LAPLA in country, was successfully rolled out as planned. As I mentioned in the slides, that the site coverage right now is approximating 100%. However, what we noted also is that we major data issues that threatens programs' ability to monitor performance. For example, we cannot monitor retention, and accurate of other metrics is also very doubtful at this juncture. We have HIV commodity stock stability issues, but now it is promising. So, hello?
I'm guessing this on the PET bar. Can you just tell me in a minute or so the other background information on? Because
so we
there's a meeting. Is there a meeting in Durban?
Hello, Jessica.
Refresh my memory about what's happened on this besides the development of this.
No, this is the new concept.
Yes, please, everyone, if you're not speaking, please mute your mic.
No, I think the first meeting is going to be on the 24th, at which we will be agreeing on this tax scheme.
Hello. So maybe
agree
I
on
should
how
raise
it's
my
going to
voice
operate and how
see if I can override it.
And do you have anything else in this, like a list of participants for that meeting or draft agenda?
No, that's what I'm developing now.
Promising.
So I should give you by Friday, I should give you the list of participants.
Tier stock levels were not optimum immediately after rollout.
And who else?
But now we have tier levels.
No, we are not. We are the convener.
Hold on.
Oh, you're the convener.
We are the convener. I think what we need to agree is who is going to be the chair.
In emergency
we have the virtual.
Prosper, 1 second, I'm going to.
Taken for partners. Do we want them to co-chair?
Prosper?
We have a teleconference tomorrow. With
Yes, is the person speaking with you?
Are they going to be co-chairing, or we need to look
No,
for
okay,
an
hold on
independent
1
chair?
second. Hold on 1 second.
In which case, during the meeting, we shall agree on the chair.
Okay.
Yeah.
So this came out of the PCB from 2013?
No, it didn't come out of PCB. It's come out of the treatment community.
Okay.
Yeah, we remember UNAIDS, we have a treatment community solely for UNAIDS. But we wanted to roll this out at regional level to bring in other partners.
All right, that's much better.
Sure.
Because I want people from that part to come, they just need to know 30 days.
Yeah, no, I feel maybe this time round it will be very difficult, and the fact that they are in Washington, that makes life even more difficult. So maybe in the future they can participate remotely, or when we anticipate to have basically three meetings, big meetings, symposia, one around HTC, another around treatment scale-up itself, and the other around the evaluation. So around the treatment cascade, we have these big 3-day meetings that will be coming up June, September, and October. Okay. Those, I'm sure they should be able to participate.
Jessica, if you right-click on his phone icon, you can mute him.
I don't know who it is talking.
It's Dr. Busywick.
Okay.
Oh, okay.
Okay. Hello?
Caesar, can you mute your phone because we can hear you?
Okay, it's done. Our apologies.
All right, so I was presenting the key findings. So what we found is that we were able to successful roll out option B+, and as I mentioned, as of December last year, we were approximating 100% in terms of site coverage. However, in this assessment, we noted data issues. This affects programs' ability to assess performance or to monitor performance in terms of retention and also other metrics. HIV commodity stock stability is promising. We had experienced some stock level issues when we started rollout, but now we have TLE stock stabilized. Rapid test kits, actually we have persistent stock level, I would say at emergency level, but we have never experienced the drastic stock out. So we have stock within the system that is able to regularly provide services, but is not optimum to the minimum requirement of stock that is required. In terms of staff capacity and space for quality care in the RSH clinic, this remains desired. And as we've mentioned, that we see retention issues that are somehow related to skills, related to data, and inadequate community linkage within our RM and CH clinics. And also space and human resource shortage compromise the privacy and quality time that a service provider need to spend with an HIV positive pregnant woman seeking care. So what we have done from the assessment finding is that emergency redistribution of TLE regimen for
Hello? Sorry, we can't hear the Tanzania team. Hello? Is the team from Tanzania still there? Hi everyone, please just give us a moment as we try to reconnect with the team from Tanzania. Apologies for the technical difficulties. Hello? Um, Unfortunately, the only thing to do right now is just to wait to see if the Tanzania team can rejoin because it's an issue of connectivity and bandwidth. So if we wait maybe 5 more minutes, hopefully they'll be able to rejoin. We're reaching out to them now. Again, apologies and thank you all for your patience.
Hello? Hello?
Hello?
Yes, can you hear us good?
Yes, we can hear you now. Thank you.
All right. Technology challenges.
Yes.
Yeah, so what we did from the findings is that we redistributed the TLE medicines to understocked facilities. We also provided emergency supply of rapid test kits. We are currently addressing data issues and overall performance. So what we've started a scoring system where health facilities in districts and regions key in data into the National Health Management Information System Gateway, and they're actually scored. One of the parameters that we are looking at is completeness of reporting or reporting rates and timeliness in order to raise the reporting issues. As I've mentioned in the previous slides, that one of the issues that we noted was underreporting, and even currently experiencing the same problem. We have incorporated PMTC indicator into the RMNCH scorecard, and this is to increase political and leadership accountability, and these cards are actually sent to the president. So whenever there is underperformance of any indicator, then the provincial management is called into action by the president. We are currently conducting periodic PMTCT and RMNCH focused data quality assessment, where we are assessing data quality across all the selected registers from the RMNCH and PMTCT registers. We are also currently designing a cohort monitoring system for mother-baby pairs because we don't have mechanism yet to report on retention. So retention measures are only done periodically. So we want to have a system that does that routinely. So we are currently in a process of developing that. We have we are already in advanced stage of developing a response system, and this is through the US government support, where the areas of focus will be commodity availability, retention into care, HIV infant diagnosis, quality of HIV counseling and testing, and data quality. And we have actually adapted and rolling out a chronic care system where we are introducing appointment and tracking system in RSH clinics. Jessica, can you change the slide for me? I don't have that privilege anymore.
We changed it. Hello?
Yeah, hello?
Yes.
Can you change the slide for me, please?
It's on the next slide, recommendations. Do you want the next one?
Yes. I want the next slide on recommendation.
Okay. Can everyone see that slide? No.
Which slide are we in now?
Okay, Prosper, I'm making you a presenter so you can.
So
Recommendations, the first slide on recommendations.
Okay, loading now.
All right. So in terms of recommendation, what we are recommending based on the experience that we have from Tanzania is that we should seriously consider data requirement in. Yeah. Yes. We should consider data requirements and appropriate adjustments to monitoring and evaluation to meet the need. For example, option B plus is essentially, we're talking about the ART program, and we know that the ART program currently does not disaggregate the information to isolate who is a pregnant woman and who is not, or who is breastfeeding and who is not. So for example, the cohort reporting system that we have for ART program only reports the cohort, does not disaggregate by age, sex, let alone pregnancy status. So for countries that are currently rolling out PMTCT option B plus should consider making sure that the MNE system, the ART MNE system is able to disaggregate by those variables. Another thing to consider is the logistics system, and this should be framed on anticipated and unanticipated events. For example, in Tanzania, what we did initially, we did a smart push of consumables because we realized that there is a requirement of a considerable lead time when facilities order the regimen of choice to when it is actually delivered to the facility. So we did a smart push where we identified facilities that we are going to start implementing option B plus. So we made sure that all the necessary tools and medicines are there before the services started. But also, I think what needs to be considered is proper commodity management. And I think this is very critical because immediately after the smart push, we experienced stock levels that were not optimal. And this was that one is that the message when we did smart push was probably not clearly understood, that they were immediately supposed to now follow the proper ordering system. So they were waiting for another wave of smart push. And I think another thing is that we are introducing chronic care within RSH platform. And I think management of chronic care requires the clinic to have all the necessary tools and all the necessary medicines available at all the time, because the chronic care is clinics that are run probably every day of the week. So they have to acquire that skills of proper management of commodities. In terms of capacity and space, in terms of capacity, we actually recommended, and what we are doing now is tapping from existing skills from ART clinic staff. So we have ART clinicians and nurses roving around to RSH clinics providing mentoring and also technical supports. We are also recommending task shifting, because now we have nurses that are currently overwhelmed with a large portfolio, now doing chronic care, like lifetime treatment for pregnant mothers, who of course later will become nursing mothers, on top of other things that they are doing. So task shifting, especially for things like adherence counseling, education, nutrition counseling, things that would not otherwise require sophisticated clinical care to be done by other rather than the nurses. This way actually to remove some of the burden that they are currently facing, and they can focus in tasks that really require their attention, of course including management of women on ART. We should consider expanding clinic spaces. We have various places where clinics are being renovated, but again, specific advocates for raising funds and expanding the clinics is very key, because currently we have facilities or clinics that do not have enough space for the existing care, let alone adding lifelong ART care within the same clinics. And we are also instituting management of appointments and tracking of clients. But also, I would recommend quality improvement efforts, because again, it's only through doing and through learning from what the team is lacking in terms of quality, we can have continuous quality improvement. So we very much and strongly recommend continuous quality improvement efforts. Next slide, please. So we would also recommend other countries, if they do not have robust systems as we were, like we didn't have robust systems, to develop and implement an emergency response system. Because we know that immediately when you start rolling out option B+, you will face commodity stability issues, data quality issues. So you have to have standing technical working group addressing all these issues, and also have a system that can regularly monitor this and provide information for action. Well, that's the end of our presentation. I would like to acknowledge my colleagues who are with me here today as the presenting team. I would acknowledge the regional teams in regions that were involved in the assessment, United States government and UNICEF, Tanzania office, the AITT UNICEF New York, and all the ministry staff that were involved in the assessment. Thank you very much. Thank you for listening.
Thank you, Doctor, and for all of the team with you in Tanzania for a very thorough and in-depth presentation on the assessment that was conducted on early lessons learned in the implementation of Option B+ in Tanzania. I think you covered a wide range of topics, from data quality to the capacity of reproductive and child health clinics to assume the implementation of B+ and early loss to follow up, particularly in the first 3 months, which has been observed in other contexts as well. So there's a lot to delve into and to ask questions about, and we encourage also everyone who's on the call to share their experiences as well from other countries implementing Option B+. So we're going to take some questions, and I'll address them to you, Dr. Prosper Pendo, and if you want to field them to your team as well, feel free to do that. So the first question is, was the retention computed for pregnant women only?
Yes. So we identified our cohort as pregnant mothers and lactating mothers. So any mother who is within the RCH setting, who is receiving or who was initiated on ART, either during the period of pregnancy or during the period where they are lactating. So it is not limited to pregnant only, but it is also does not include men and children on ART.
Okay, great. Thank you. And then the second question is, what are the dropout rates observed at 3 months, 6 months, and 12 months in Tanzania?
According to the data that we had during this assessment and recently concluded pilot, but not validated data, the dropout rate is around 30% at 3 months. But again, I'm throwing in a caution that the retention is measured at registry level, and therefore we have experience where women show up at the clinic, they receive care, so records are updated in their clinical files, but is not transferred into the register. So the retention that we are measuring, we're using the registers. So we have quite a number of missing data in that sense.
Okay. And do you have any indication, this is sort of a follow-up question of why that's happening?
Why is what happening?
That the registers, sorry, did you say that the registers, maybe I misunderstood, but that the registers are reporting, there was a comment in the presentation that there was underreporting.
Yes.
Going on.
So maybe to put it in context is that the way that service is delivered is that a client comes to the clinic, and on the course of service provision, the clinician or a nurse would record the services provided in the client's file.
Mm-hmm.
And later that file is either updated within the electronic registry, if that facilitates the electronic registry, or on a paper-based register. So that is what usually does not happen.
Mm-hmm.
So you have people coming to the facility receiving care, so they're actually retained, but it is not transferred into the register.
Right.
And retention is actually measured within the registers, because there is where you can have a cross-sectional snapshot, or a follow-up snapshot of all the patients that have been registered within these registries. So, for example, a patient X may have visited the clinic in January, February, and March, but only the January visit has been updated into the register, and then February and March is only in the patient file, has not been yet transferred into the register.
Okay.
So in a sense, you say that this client is not retained in care, but really it's just the information from the client file has not been updated into the register.
Okay, great. And the next question is just a thank you for a very clear presentation, and to ask, what are the national protocols for follow-up on missed ART visits?
Yeah, so we have a protocol for follow-up of missed appointments, and usually it's for people who have not shown up 5 days after the scheduled appointment. So if they have not showed up 5 days after the scheduled appointment, their name and identification number is transferred to what we call a tracking register, from which now the health service provider at the clinic shares this register with the either community health care worker or a volunteer to follow this patient up. And if this client had provided means of contacting them, either a mobile phone number or something like that, then they are called. And this patient will be declared lost to follow-up if this effort has been undertaken to no avail, and that 90 days have passed since their last appointment, then they're declared as lost to follow-up.
Okay. Yeah, I think that's clear. And if anyone has any follow-up questions based on the responses, also feel free to send those in. So the next question is, how many of the 802 started ART? So I think that's a reference to an earlier slide.
Yeah, so the policy that we have for option B plus is test and treat. So these women essentially are the women who tested HIV positive, and they were immediately given the unique identification number and were started on ART. So I would say essentially all were initiated on ART. However, I would like to acknowledge that we have had reports of women who would decline starting ART on the first day that they learn of their HIV status.
Okay. And the next two questions have to do with the rollout of option B plus, and the first is really about what was the secret to achieving a nearly 100% rollout in terms of expanding to so many sites so rapidly? And then linked to that is, after you rolled out option B plus, do you have an idea of the before and after MTCT rates? So was there any significant decrease in the mother-to-child transmission rates?
Okay. So first, the secret to the rapid rollout, I would credit that to the in-country collaboration between all the stakeholders and partners, because there was an intensive preparation before the rollout started. And as we mentioned, that we quickly conducted this assessment after the initial phase of the rollout to inform the subsequent rollout. So some of the issues were able to be addressed because of the lessons that were learned through the assessment. So what really transpired is that there was an in-depth discussion on the decision to move the police to the current option B+, commitment of resources, both from US government, the government of Tanzania and other stakeholders, including the UN agencies, preparation of all the necessary resources in terms of training materials and conducting the training, production of data tools, and also, as I've mentioned, the smart push of the required commodities in order to provide the said services. So I would attribute the rapid scale up to that, and also the political commitment that our president and the first lady are pushing for making elimination agenda a reality. What was the follow-up question?
The follow-up was MTCT rates. Was there a difference before and after?
Right now, we really don't have, because as I mentioned, we have some data issues. And the way that we are measuring MTCT here in Tanzania, we are doing mathematical modeling. However, we have evidence from the PCR labs that shows a significant decline in HIV transmission among children that have access to HIV and infant diagnosis, where according to the lab data, I think at the end of 2013, the overall transmission was at 6%. However, that is not representative of all the children that are HIV exposed in the population. We are yet to analyze data for 2014 from PCR labs. So by then, I think we'll have a very good guesstimate on what is the transmission rate now.
Okay.
Yes, but maybe a point to note out there is that on the previous data that we analyzed, because we are also recording the intervention that the mother received, there was quite a superior outcome for women who were receiving ART, and for women who had started ART early in the pregnancy as compared to those who received only prophylaxis or those who missed out completely.
Okay, thank you. And just to say to everyone, if you want to verbally ask your question on the mic, so it's a broader discussion, and it's feel free to just ask a question and unmute your microphone and ask the question directly, so you don't only have to type it in. We're happy to hear other voices on the webinar as well.
Maybe if I could respond quickly to some of the questions that I can see here.
Yeah, if you want to.
Question from Fatima Sioris from ICAP, and she's asking, are the standalone sites with no collocated CTC providing ART to male partners if tested positive, and how long are women followed in RCH at these standalone sites? So the policy right now does not allow us to initiate treatment for male partners, so they are referred. However, we have granted partners that are supporting implementation of PMTCT to write protocols for operational research to see whether that is feasible and doable. So once we receive those operational protocols, we will grant permission before this becomes a policy. And women are followed for approximately 3 years within the RCH clinic. Yeah, that is the period of pregnancy, and then 2 years after that is the follow-up for mother-baby pairs. We have another question from Landry. He's asking, how did you manage capacity building for ART initiation to reach all nurses in 2005 sites in less than 2 years? So what we did is we did a cascade training where we developed a pool of trainers, of national trainers and regional trainers. And then these are the ones who went out to provinces and health facilities to train these nurses to be able to provide ART. So as I mentioned, that many of the sites that we have currently co-located with ART clinics. So the capacity the capacity building was in cascade manner, but there is also ongoing mentoring, supervision, and on-job training for some of these health providers that have not received proper didactic training on option B+.
I think on what did not work well.
Yes. Mm-hmm.
Yeah, so on what did not work well is what we found is that if there is no immediate follow-up, following training, then of course the providers do not get as good skills as the ones who have a regular follow-up. So I think the follow-up that Prosper mentioned, that really did contribute, but when no immediate follow-up, then of course you get the challenges where the providers don't have as good skills as the others.
Yeah, and again, as Landry has put it, that we were very successful in terms of site coverage, but we are experiencing challenges in terms of quality, as I've highlighted by the assessment findings. So quality, I think, is something that takes considerable time to institute. Even the ART program did not have this success that they are enjoying overnight. So it's something that has to be continuous, to undergo continuous improvement. That's why one of our recommendations is really, because the skills are not acquired in one sitting of training. Skills are acquired over time. You need to practice, and you need to practice right. So continuous quality improvement is one of the pillars that will actually see the success of the implementation of option B+. Then Yahe want us to talk more on the mother-baby cohort. When is the cohort started at pregnancy or after birth? What if they give birth at different time? So what I think it's quite a lengthy discussion. So this is still is at an advanced stage in-country discussion, and what we are doing is we are starting the cohort follow-up during pregnancy, and we are treating the outcome of the birth as an outcome of pregnancy. So you're practically following the same mother across the cascade, and we decided to design it this way because we noticed that if we had cohorts at postpartum period, we will definitely lose women who deliver at home and never come back to the facilities, or we'll have that disjoint that we currently observe between antenatal care and postnatal care. So we decided that the cohort should start at the time of pregnancy and follow that woman for the period of 3 years. And so the baby is treated as an outcome. I'm sorry to say that for child-sensitive audiences, but we couldn't find another way of overcoming that.
Thank you. Can I speak?
Sure.
Yeah, I'm Anandi from India. Thank you so much for that excellent presentation, and very systematic, and you have documented the whole process. It's really indeed very enriching to me, coming from India, and we're just sitting, in a workshop where we are discussing about the stockout issues for the whole ART program. And many countries are also moving towards that TLE combination. So I think it's very important that this needs to be addressed. My question is about what percentage of positive pregnant women go for institutional delivery of those who are being put on option B or option whatever, B or B+, and so what is the percentage of institutional delivery among those? Because it's very important in many settings. It is especially in our RCH settings, where what happens most settings, like the moment positive pregnant women is tested HIV positive, they are referred to ART clinic and where they are managed with the option B regimen, and then they are sent back and forth. So how does dealt within the sittings, and because its stigma is also a huge issue.
We don't have national data for that, and one is we don't have indicator for that. But also we don't have a cohort follow-up system where we could record as how many among the PLHIV women actually delivered within our institutions. However, evidence from some of the clinics in township indicate that delivery among pregnant women who are HIV positive is very high compared to that of the general population. But I cannot concretely give you a point estimate right now. But the institutional delivery in Tanzania for every other client is at around 50%. So actually, and I think what we've asked actually underpin the importance of doing a cohort follow-up, because then we can identify where we are facing a challenge at which particular period in time of keeping these women in care. Okay. We have another question that I'm reporting that 73% received ARVs. What happens to the other women? So this is what we get through the reports. As I've mentioned, is that these reports now depends on how accurate the update within the registers are. And evidence indicates that we are providing more than 73%, and then, but this is what we get at the national level. Yeah, so
not offered, they are initiated.
Yeah.
I think it's, yeah.
So 73% is not the percent who are offered, but these are the ones who accept after being initiated. And there is another question in how was the acceptability of the rollout by both healthcare workers and the clients. I think the healthcare workers, the acceptability among healthcare workers was quite high. Of course, they were concerned on whether they would be able to provide lifelong ART care. So these fears were alleviated through trainings that were conducted, and also ongoing mentorship visits that are being conducted in supportive supervision. And among clients, acceptability, especially among pregnant mothers, is very high. What we are concerned about is what is the acceptability once the final status of the baby is established, that the baby is HIV negative. And we know that right now, the cornerstone or the linchpin of the acceptance is pinned on their desire to protect the baby to be HIV free. So what happens after that? So I think our cohorts are quite young. We don't have very much mature cohort to be able to answer that. And secondly, we don't have a cohort monitoring system. We are currently developing it. So I think this is one of the critical questions that every member of the PMTSD community will be asking, and I think it's something to consider as we are implementing option B+. Maybe some. You can't hear us?
Hello? So, Dr. Prosper, just in follow-up to that, are there women who decline starting ART? And if so, what happens to them, or what services are offered to them? And then there's another question related to women who might not want to start on the day of diagnosis. They might need to process the diagnosis and might start later. So is there any information in terms of time to start ART between diagnosis and actual initiation?
Yeah, so right now the police recommend testing and start treatment, but we have field experience where some women ask for some time before they can start treatment, and these are given time to do that. And then we have women who refuse treatment altogether, and these are usually given the alternative of receiving prophylaxis. But what we have noted so far is that these women who receive treatment refuse treatment, refuse ARVs altogether. So many of them do not even want to receive prophylaxis. So what is done is that these women are usually identified by the facility staff, and then special attention in more counseling, assurance, and disclosure services are provided in order to enable them to negotiate that difficult time between diagnosis and starting treatment.
Okay, thank you. Yaye, I think you wanted to ask a question. Hello? It's a little difficult to hear you, but please ask your question. Yeah, it's hard to hear you, but we do have your question about discordant treatment. So her question was regarding how is discordant treatment provided, or how is treatment provided among discordant couples? Hello? It looks like we might have lost Tanzania again. But I think we'll just take this time to wrap it up and thank everyone for joining us. We had over 70 participants at the height of the webinar, and we are very appreciative of all of the work and the time that the Ministry of Health and Social Welfare from Tanzania put into this presentation and in sharing the findings with us. In particular, Dr. Prosper Pendo and the PMTCT team, as well as everyone that he recognized, UNICEF Tanzania, the USG, the IATT, who supported the assessment. So we'll be distributing the presentation and the recording of the webinar very shortly for those of you who want to review it and share it with your colleagues. We encourage you to do so. If you have any questions regarding the presentation or the findings, please reach out to us, and we'll put you in touch with the team from Tanzania. And we encourage any other countries who are interested in sharing your experiences, whether on the implementation of Option B Plus or any other innovative strategy regarding the elimination of mother-to-child transmission of HIV. We would gladly feature your presentation. So thank you again to everyone who joined us, and we look forward to seeing you shortly on our next webinar. Thank you so much.
All right, thank you so much, Jessica, and see you soon.
She's going to come. I'll let her to come. Excellent process.
Thank you.
Congratulations.
Congratulations to us.
Thank you. That's a lot of work. Interesting.